Good morning. Good morning. Good morning. My name is Anthony Boswell. I'm Senior Vice President for Behavioral Health Network, and I have no actual or potential conflict of interest in relation to this program or presentation. As a recovering attorney, I wanted to get into that statement, but I'm going to spare you that this morning. I'm here to speak about the underbelly of the beast. As you all know, every single day in this country, communities are torn apart by the opioid epidemic. I was glad to hear that the numbers have gone down, but there are still way too many people experiencing this scourge. Behind every number is a person. It's a family member, a friend, a child, a cherished loved one. As you all know, OTP programs are one of the most effective tools in dealing with this scourge. Effective opioid treatment is not just therapy. It is a structured, multi-layered medical and psychological care delivered within a tightly regulated framework. Experts estimate that for every $1 spent in treatment, society saves approximately $4 to $7 in reduced healthcare and crime costs. That is one hell of an investment. I have a friend who's big into Bitcoin, and he can't say it's that good. BHN operates I learned today. BHN operates 7 OTPs and 2 medication units. And Chris was generous enough to share the location, so I won't get into that. And the need for these clinics and units is undeniable. But what does it really cost to open and run or operate an opioid clinic treatment center? So when I was told that I would be doing this presentation, I saw the title, and the title spoke to the underbelly of a beast. And I took one drama class in high school, so I wanted to act out the beasts that might be at play here, but I thought better of it. But I did consider a few beasts. The first beast I considered was Godzilla. And Godzilla's old and worn and not really interesting anymore. The second beast I considered was King Kong. And King Kong is also old, but I was always impressed by Denzel Washington's line, "King Kong ain't got nothing on me." But what I settled on was the Kraken. The Kraken is a mythological Norse sea monster in the shape of an octopus or squid with 8 tentacles that drag Viking ships down to a cold, watery death. In discussing the finances of an OTP, we're going to talk about the expenses that are known, anticipated, planned for. But we're also going to discuss those costs that are unanticipated, or maybe not fully anticipated. And those costs are the ones that can, like the Kraken, drag your operation down to a cold, watery death. I told you I was dramatic. So a full appreciation of the costs is important because it's not only a good gesture, a good deed, and as we discussed, society benefits from opioid treatment centers that open, but more importantly, just opening, it's important that you stay open and you continue to serve the community. We live in trying times, beset by challenges on all fronts. And to paraphrase one of my favorite songs from the 1970s, what the world needs now is love, sweet love. And I want to modify that to say what the world needs now is love, sweet love, and sustainable, effective opioid treatment programs. So let's talk about the explicit costs, and I have 4, and I'm not advancing my slides here at all. Okay, these are the objectives, underbelly of the beast. Okay, So we've all seen the iceberg illusion, right? And this is just another reference to what we see up top of success. We see the nice cars, we see the beautiful men and women, we see the celebrity balls, but what you don't see is the sweat tears that got you there. And the point was, it's the same with centers. You see the obvious costs, which we're going to discuss now. And I'll start with first, licensing and accreditation. An OTP, as Dr. Phoebe, I think she's still here, she shared, an OTP has to be first certified by SAMHSA, registered with DEA, and licensed by the state's health department, our friends at BSAS. Each of these steps has fees, application costs, and an associated wait time, sometimes many months. And I just want to clarify, for the sake of our relationship with BSAS, I want to say we never have to wait. Hear back from them very quick. With all of these costs, means you're paying operational costs like rent and utilities long before you see your first patient. Additionally, accreditation is required, and we just went through our CARF accreditation, and that can run anywhere from $12,000 to $20,000 every 1 to 3 years. So I estimate that licensing and accreditation costs approximately $20,000 as you start out. The second anticipated costs are facility. Our facility expenses. We all need a place to call home, and our OTPs are no different. Whether you lease or purchase, any OTP must meet stringent security and clinical requirements: separate dosing rooms, secure medication storage, private counseling, Americans with Disabilities Act accessibility, and a waiting area that supports patient privacy. And we at BHN learned this year that we also have to have children's play areas. So imagine running an OTP while stepping over Play-Doh, Legos, and Star Wars action figures and listening to Baby Shark. Renovations and compliance upgrades can cost tens of thousands to hundreds of thousands of dollars. I estimate $200,000 as part of your startup. Staffing costs. OTPs require a highly specialized multidisciplinary team of physicians, nurses, counselors, medical assistants, administrative staff, and sometimes security. Many states mandate minimum staffing ratios before you open, which means you cannot start with a skeletal crew. Estimated cost, $300,000 plus. And finally, the anticipated costs, medication costs. Purchasing methadone, buprenorphine, or naltrexone in bulk, storing them securely, and ensuring a consistent supply chain all require significant upfront investment. Once again, estimate $50,000 a year. So sitting with anticipated costs, I anticipate between $400,000 and $650,000 of known costs. But what about the hidden costs? I have 8 hidden costs. And I thought it was cute because octopus have 8 tentacles. Regulatory compliance maintenance is one. Opening the clinic is just the first hurdle. OTPs face ongoing inspections from federal, state, local agencies, and you'll need to pay for continuing ed, compliance consultants, staff time to prepare for audits, et cetera, et cetera. As many of you know, well, I hope you don't know this, but as many of you may have heard, a single failed audit can mean costly remediation or even temporary closure. Estimated annual cost, $10,000. Some of these have been covered, so I'll run through them kind of quickly. The second unanticipated cost would be increased insurance and liability coverage. This is the room that I've been in with the most physicians in a long time. And I know you all know malpractice insurance for OTP physicians can be significantly higher due to the complex nature and delicate nature of opioid treatment and addiction medicine. You'll also need general liability insurance, cyber coverage, property insurance, et cetera, et cetera, et cetera. Estimated annual cost, upwards of $40,000. Hidden cost number 3, security, infrastructure, and personnel. Methadone and other controlled substances require advanced security, safes, alarms, cameras, control entry systems, and some clinics must hire on-site security guards, not for safety, but as a part of the license. Estimated cost, $50,000 setup plus salaries. Thank you for. There you are. Thank you, Ruth. Technology, you'll need an electronic health record compatible with 42 CFR, which is obviously more stringent than HIPAA. And this may mean specialized software with higher licensing fees, integrating with prescription monitoring systems and billing systems, which add complexity and cost. Estimated annual cost, $50,000. 5 is unreimbursed or under-reimbursed care. I won't get into that into too much detail, except to point out that your new clinic will bear the cost while you're waiting to be paid. Number 6 and 7 are really important, and I think Dee alluded to it earlier. An OTP is not always met with open arms in the community. We live in increasingly polarized times, and in this age of low tolerance and low acceptance of those not like us, the isms are becoming more apparent. Not just sexism, racism, but NIMBYism is a big ism that we deal with. One community issue that you'll need to deal with is building a relationship with community. In our new location in Somerville, Gretchen, who'll be speaking shortly, and her team spent a lot of time and did an amazing job building relationships, delivering presentations, and generally schmoozing with the local business community. For your OTP, you will need to invest in community meetings, outreach campaigns, and public education to counter stigma. The cost of earning trust in communities is real, it's measured in dollars, and it's ongoing. I estimate approximately $20,000 annually. Number 7, only 2 more left, hang in there with me. Staff burnout and turnover. Addiction treatment is emotionally draining and demanding. Staff burnout can lead to high turnover, which means recruitment costs, training costs, et cetera. If not careful, it could lead to potential and temporary drops in quality of service that you provide. To keep good people, retention strategies such as professional development, wellness programs, and competitive salaries are a must. In a recent study, the Society for Human Resources Management, or SHRM, estimated that in a highly regulated business such as healthcare, and depending on where in the country your operations reside, it can cost a minimum of $5,000 to recruit and hire one quality staff member. So with a modest team of 10, you're at $50,000 in recruiting and hiring. At BHN, I spoke to our HR department, and it was estimated that it costs us anywhere from $8,000 for unlicensed staff to $12,000 to recruit professionals. Dr. Poteet cost us $12,000. She's worth it. She's worth it. And lastly, but not least, unexpected legal costs. I used to play an attorney on TV, and employee grievances and relations, compliance challenges, all of those issues can mount quickly, and it's better to have a plan than to deal with costly mistakes. I estimate total hidden costs in the range of $350,000. So, what is my call and conclusion? An OTP clinic is at once a public health necessity, business venture, and a test of community resolve. The direct costs are significant, but the unseen burdens, it is the unseen burdens that so often determine success or failure. Adding it up, opening a modest OTP can cost anywhere from $500,000 to $2 million. Ongoing operations can easily exceed $2.5 million a year. It's not about good intentions, it's about realistic planning. The visible costs are just the tip of the iceberg. Beneath the surface lie other significant costs that we've discussed. Whether you're a policymaker, an investor, or a community leader, my goal is to get you to look beyond the numbers on the surface. plan for the full reality, and advocate for sustainable funding and oversight. Only then can we effectively and powerfully confront the epidemic. And when we prepare for it all, the seen and unseen, we're not just building a clinic, we're building hope, stability, and a lifeline for those ready to take their first step towards recovery. Thank you. I have the privilege of being the opening act for my colleague. She is going to discuss with you how to effectively and appropriately bill for your OTP services. Please join me in welcoming a compassionate, energetic, and tireless advocate for those that we serve and for her staff. Gretchen reports to me, and I hear it every day. Let's do something for them. Please, Tony, let's say thank you. Let's have a party. A tireless advocate, Gretchen Schwelm.
Hi, everyone. My name is Gretchen Schwelm. I'm the Senior Program Manager at BHN for our Eastern OTP and OBOTs. So I had the pleasure of overseeing the expansion into the East. So I just wanted to give a little information, background on why OTPs are so important. I think a lot of this information has been gone over by other providers in the community and BSAS itself. So just looking at the amount of people that we have and this keeps going forward on itself, I don't know why, with opioid use disorder. And then I hate being wrong, but I love that I'm wrong on this slide because I got this data, the 55 brick and mortar OTPs and 3 mobile OTPs from the 2024 geographical support report, and we now have 5. So that's incredible. And then we also have the 6 medication units. And if you don't know anything about opioid treatment programs or OTPs, and this is all new to you, I didn't know anything 2 years ago. And now I would say I have like a tiny bit of knowledge with it compared to everything there is to know. And then the amount of individuals that are receiving methadone treatment. So as you just heard from my colleague, the cost to run and sustain an OTP are astronomical. So how do we bill ethically and appropriately so that we can increase revenue, stay open, and not only that, but like really provide, I need help. But really provide the continued services. And like other individuals have talked to, being able to give people, I don't know why it keeps going forward on its own. Okay. But being able to give individuals all types of services. So when you come to an OTP, how amazing would it be that you can do yoga there too, or that you can do a music therapy group, or that you can upskill all of your staff to be able to do the things that they love doing. And we're able to do those things if we're billing right. Like we have additional revenue to be able to provide those services. So if you look at this in Massachusetts, it kind of breaks it down by payer type. And this is something that we're going to have to really look at with the way things are changing federally. So you have individuals on Medicaid treatment, quite a large number, 1.65 million. That's a combination of Medicaid insurance and connector care insurance, which I call commercial Medicaid, but it's not necessarily. And then Medicare insurance, there's 1.3 million. And then we have commercial insurance, which is its own entire ball game. It literally has different rules by every single payer, different reimbursement rates for everything. So it's really taking the time. As you see, OTP rates vary by commercial payer and contract type. You always want to refer to the payer manual for that. So CMS came out in 2024. This was a part of the final rule, and it gave kind of greater access to be able to bill for additional services that are provided in the OTPs. So both Mass Health and federally, CMS came out and said, you know, we can reimburse now for coordinated care referral services. We can reimburse now for patient navigation services, so recovery support navigators. We can reimburse for peer recovery support services. So it's looking at not just that like bundled rate that most OTPs get. It's looking at the additional service and add-on codes that we can do as well. So this kind of goes over everything that was included. It includes substance use counseling, intake activities, toxicology testing. Historically, we had moved to what you've heard so far have been called the G codes, and usually everything was covered in that. And then, as I'm sure a lot of you who work know, there are days where you're spending 6 hours trying to help get someone into detox, an ATS, or a higher level of care, but you're not getting anything extra for that. And I know I would spend probably 6 days trying to help someone if need be. Like, that's who I am, that's who my staff are. So it's looking at these ways and how we can add on appropriately so that we can continue to provide them. They also didn't update, which is pretty unfamiliar to some people, at least with Medicare. Historically, they would only reimburse most of the plans for LICSWs or higher. And this came out in 2024. They now reimbursed for LADCI as well. They'll reimburse for LMHCs and LMFTs. It is a little bit different. It's a 75% reimbursement rate of what you get for an LICSW. But this kind of expands to being able to hire more professionals to provide services. It makes it a lot easier. I know, as someone who's also served in the role of state behavioral health director, trying to manage caseloads and make sure everyone's matched up with the right provider to be able to receive reimbursement, it can get tricky. So allowing this to happen really expanded access too. So here we just kind of go over the different rates, and a lot of times people don't know like what they could essentially add on and like how this would work. So everyone knows most of them. We have a weekly bundled rate that includes the methadone in an OTP. So that's pretty substandard. That's pretty easy. And then you have patients that are on a variety of different amounts of take homes, and having to like align that and get that to work with that can be tricky. There's also a weekly rate that's no medication, and it's providing services in addition to what's outlined in a patient's treatment plan. So that's kind of where these other activities, these other groups come in. Really being able to specialize treatment would allow for, say, someone that's on 28 days of take homes, if they come in on a week that like they're not receiving medication and they come in for some of these specialty groups, there's a higher reimbursement rate that you can get. So it goes through, we have periodic assessments, which is when a patient would meet with a medical provider, would review dosing. And it's really learning by payer type which one of these really would actually reimburse. You don't want to overly bill ever for services. That's not appropriate. We don't want to take advantage in any way, but you do want to bill for the services that you are providing. So one way of increasing revenue is really providing excellent groups and wraparound services in that component. It's hiring recovery support navigators for your OTP, hiring recovery coaches for your OTP, and then coordinated care, which I kind of touched on. Any single time you're working with individuals to get them the wraparound services. I know for people in recovery, it's extremely hard to be able to reach recovery and reach abstinence, or not necessarily abstinence, but their level of like what recovery looks like for them if their basic needs are not met. it's impossible. So like I say to my staff all the time, we will do whatever it takes to make sure every single patient has clothing, has food, has insurance, has whatever they need to be taken care of. And I'm lucky enough that I have staff that will go above and beyond to make that happen. I knew I'd get the sign. I'm a talker. And helpful hints for OTP billing. So these are just a couple things that like you want to make sure your billing team's doing. Full disclosure, I've never been directly on a billing team. This is all research that I've done. And we're actually in the process of trying to like review our own to see how we can do this more appropriately. It's a lot. I would never want to run an insurance department. I remember when I first got into this field and I didn't know the difference between Medicare or Medicaid. And if anyone still doesn't, Medicare is the one for people that need more care. So anyone that's elderly or disabled or anything like that, that's how I remember it. If you need a helpful hint. But really, it's been a lot of research over the past couple of years to be able to understand this better. I love knowledge and I love being able to really look at how you can build revenue to be able to provide the best patient care possible. Like not to line anyone's pockets, but to like funnel it back into our patients and our staff is really what it's about. All for investing in upskilling people in different areas. I have a clinician in my hyannis clinic, which is one of the medication units that just opened. Literally just got the text that the methadone was delivered. So that's amazing. We go live on Monday. And she wants to do horticultural therapy and like look into that. I'm like, let's do it. Like, let's see what we can figure out. And we have the space there. So really just seeing what we can do to help provide better care for people. And so what do we got? We got any questions? We got any feedback? All right. References. Oh, and a quick shout out. I am obsessed with the dashboard. I talk about it all the time. I even brought it up. I met with North Attleboro Health Department on a call. I'll pull it up on calls with community providers. I'm like, this thing's amazing. You get so much data. And she's going to use it to try to get more people on board in that community to be able to give out fentanyl strips and things like that. So it's an amazing dashboard. Definitely use it. I'm using it for everything.
Thank you so much. Thank you. Your tips and tricks are really helpful, and I think really kind of help explain how to determine to get out of that bundled rate system into this more tailored system. Sorry, this is Melissa Schammel. I work at JSI Research and Training and am not a public speaker. I run the TTA Center in Massachusetts, funded by BSAF. And this issue comes up quite a bit. This is like the #1 issue. And so I'm wondering if there's any work groups happening around this to figure this out, or if you're the only one doing this, because I think this could be something that is really helpful for a lot of OTPs if it were more available or more collaborative in that discussion. So I'm very excited by this presentation and would love to speak to you after this.
Yeah, definitely. I would love to do a work group with multiple OTPs and all of us working together. I'm working to coordinate a meeting next week, one of the regional for CTC. Like, I'm excited about that. Like, we want to collaborate with everyone. So I would love to get that going.
Thank you so much.
Hi, I'm Wisam Lee from Mass General. For those of us who don't work in OTP, this is wonderful. A few months ago, I emailed Ruth about a patient to try to, speaking of CTC, who is at one of my primary care patients who's at a CTC, and he told me his copay is $18 per dose of methadone, which comes to over $6,000 for a gentleman who's not working because he and is fighting. I'm constantly filling out his disability or short-term disability paperwork right now. So just for those of us who don't work there, I'm curious. We presume most patients who have Mass Health have zero copay, but what does it look like for everybody else? And is that it doesn't sound common, but what does it look like for copays for the patients?
Yeah, so Mass Health, there are no copays. Anywhere that has, there's multiple parts of Medicare. So there's Medicare A, B, C, and D. Most people have Medicare B for these and they do not have copays either, but there's co-insurance fees. So there might be like a back end fee, so they wouldn't have to pay to dose. Most commercial plans, unfortunately, do have a copay. So ways essentially around that is really to work with the individual, and if it's medically and clinically appropriate, to advance them as quickly as possible on take home so that they're